is obtained from creatine. It is obtained from creatine. What is creatine? Creatine is a high energy compound. It is a high energy compound which liberates loads of energy, enabling your muscles to contract easily and release energy requirements. Okay? That is creatine. Now, this creatine will, after spontaneous hydrolysis, becomes creatine phosphate. What do you mean by spontaneous hydrolysis? A water molecule comes out of its own. There is no enzyme working for it. It is a non-enzymatic pathway that a water molecule is expelled and the creatine becomes creatine phosphate. And then this phosphate group is moved. That is dephosphorylated. And it is dephosphorylated to form creatinine, which is an excretory product. Okay? The phosphate group is then dephosphorylated to form creatinine, which is an excretory product. Now, what are the typical features of creatinine? What are the typical features of creatinine? The first and foremost, most important role of creatinine is it is mostly fixed. The amount of creatinine is mostly fixed. The amount of creatinine that is present in your body is mostly fixed, and the amount of creatinine that is supposed to be excreted in urine through normal physiology is also fixed. Why? Because it depends upon your body mass, body muscle mass, and it is not easy to change your body mass. It is not easy to change your body muscle mass. In order to do that, you either need to go to an intense exercise level or you need to undergo a severe state of food deprivation in order to change your body muscle mass. Yet, how is it not help to us? There is a sudden increase of your creatinine levels in blood. What does it say to you? Something is wrong. This fixity of creatinine allows us to use creatinine as a parameter in order to analyze what is your GFR. That is your glomerular filtration rate, thereby giving you an idea of the entire kidney function. Thereby giving you an idea of the entire kidney function. Okay? Suppose you are dragged all around the college. It is there for a day. Next day, your blood creatinine levels are estimated. Will you find any change? No, you will not find any change. It is fixed. And in accordance to muscle mass, it varies. There is a very mild variation that is in accordance to your body weight, your gender, and your age. That is why we are using creatinine to make an estimate of the kidney function. This will give you an idea about the condition of the kidney. Now, the condition of the kidney can be changed under two circumstances. It can be changed under two circumstances. The first circumstance being the presence of unborn kidney or find normal kidney function in that patient? Yes or no? Do you find a normal kidney function in that patient? Yes or no? Yes. Very well. Fine. Because whenever the body is at an onslaught, our internal homeostasis has a tendency to provide extra blood supply in the affected organ to keep it functioning. Okay? So suppose you have had a heart attack or a myocardial infarction, the natural tendency of the body is to shift more fluids to the heart so that it can be well perfused. Okay? Who supplies it taking off from? The kidneys. It is taking up basically the blood supply of the kidney. Any insult of the body, any injury of the body, the blood supply of the kidneys will be cut off and it will be directed and it will be the affected organ system. But the good thing for us is kidneys are a very resistant organ. Kidneys are a very resistant organ. So they can function properly even after 48 to 72 hours after its blood supply has been redirected to somewhere else in order to protect the organ. Okay? In order to protect the organ, the kidney can function well up to 48 to 72 hours. After that, due to lower renal function of the kidneys, with time, slowly the renal function deteriorates due to ischemia of your nephrons. And when the patient has in that condition, we call it ATF or ARF, acute renal failure or acute tubular necrosis. Acute renal failure or acute tubular necrosis. The organ being at this stage, the injury to the kidneys can be stopped and reverted. It is not a fixed condition. The damage is not permanent. So if the patient adequate therapy, the kidney function will improve. It is a transient state. Okay? But if this condition is not reversed, then the patient will acquire permanent kidney damage. There will be death of neurons, there will be death of nephrons. The amount of nephrons that is present in the renal system is about 3 billion. 1 to 1.3 billion. So as these nephrons are killed or die, your ability to secrete urine and your renal function goes down. That is what happens when you have a exogenous disorder. Exogenous, I mean non-renal disease. So suppose you have a very high fever consistent of second. Now, if you tell me why you will get this, you are going to why that is important. Because you never know that an active metabolic state has caused any injury and whether you need to reverse it. That is why if your renal function test is given along with liver function test as a screening tool for all patients having a linear part can only be reverted within 48 to 72 hours. After that, it becomes permanent damage. After that, it becomes permanent damage. So the funny thing about creatinine is, it is neither secreted in the tubules nor it is here. So the amount of creatinine that is flowing into your kidneys is more or less constant. The amount of creatinine that is flowing into your bloodstream and is flowing into your kidneys is more or less constant. So with the ratio of these two, it is almost fixed, and that is called creatinine clearance. The ratio of the creatinine that is being excreted in one circulation is fixed, and that is called the creatinine clearance. And we are using this creatinine clearance in order to estimate our glomerular function. And how do we do that? We do that with the help of the blood model. And what does it say? It is 170 into 170 minus H by 88 K multiplied by 170 minus H divided by 88 concentration. This will give you an approximation of EFR or E units. It will give you an approximation of EFR or E units. So the EFR is inversely proportional to the creatinine concentration. That is, if the creatinine concentration increases, that means there is accumulating of. And with this formula, we have been able to classify renal disorders into 5 classes. Stage 1, Stage 2, Stage 3, A and B, Stage 4, and finally Stage 5. Okay? So the Stage 1 is greater than 90% of the premade function. Stage 2 is 60 to 90%. Stage 3A is 45 to 60. Stage 3 is 30 to 45. Stage 4 is 15 to 30. And finally, stage 5 is less than 15. And this is called ESRD or end stage renal disease. When a person is in the class 5, that is in ESRD, then the person does not have the capacity to form urine anymore. That person is dependent upon diet, hemodialysis to take care. The person is dependent upon hemodialysis or influx. Exactly, good. What is the renal? This will be asked in your first year. It will be asked in your second year. It will be asked in your final year. And if you are a serious thinker, it will stick with you your entire life. Remember 90, remember 15, remember Urea. You like the urea? You like the urea? Not like the urea. Okay, very good. Not like the urea. You want the urea to make your body further. Okay. Will you start smelling like the washroom? Okay. So what is the funny thing about urea? Why do you need urea? Tell me. But why do you need urea? Is there somebody else? Why do you need urea? Why nature made urea? Where is it coming from? Government. I have repeated this so many times. Where is urea coming from? Urea is the best product of what? Brain tissue. If your brain tissue die, will it give you urea? Yes or no? Wait, what? If your brain tissue dies, will it give you urea? No? Very good. It will. Because our body is made up of proteins. And these proteins have a variety period. If it is within variety period, it will be replenished by the company. The company gives your body. And if it is outside your lifespan, you will get there. Then you are supposed to suffer for it. You got to pay. That means that it will help. So urea is basically coming from ammonia, which is coming from the breakdown of proteins in your body. Okay? Because the proteins will inevitably become what? A unit of proteins, amino acids. You remove the amine part by the help of oxidative deamination, glutamate dehydrogenase, to produce this urea by that. Isn't it so? Penile urethra. Where? Liver, right? Or some liver. Do we like water? Do we like water? No, we don't like water. Why don't we like water? I want to excrete ammonia from my urine. I do not want to convert it into urine. I don't want to transform water. Yes, the amount increases that will cause hyperacidity in your CSF. That will cause alkalosis in your brain. And that will cause your inner parenchyma pushing class. This excess of ammonia will be converted into GABA-aminobutyric acid, which is a negative neurotransmitter, and that will keep you accumulating in your brain. You start having fatigue fevers ending up in coma. That's why we don't like water. We are in love. Okay? We love our food. So what we are able to do? We are going to put it in a urea cycle, which is actually a bicycle, to make urea and excrete it. Funny thing about urea is a very critical product. Sometimes here, sometimes there. The amount of the varies from 0 to infinity just like limits. Okay? You got dehydrated, you have increased urea. You did not take proteins at all last night, you have increased urea. So urea gives a snapshot of your body metabolism at that particular point, and it helps you to give point intervention for prevention of disease. Okay? It gives you a small opportunity to give point information in prevention and fighting. That is the application. Okay? Now, let us come to the parameters and what you will be actually needing to know. So, AFP or RFP. In AFP, you have India, You need to but there is no other way in your life. Vomit it out for the next 40 years of your life, that is it. And here the rest is capacity to become the partner. Okay? Okay. Got it? So with this, we have finished our small lecture of renal function test. Happy?
Because parliamentary knowledge is very important for people to understand our activities, to understand different types of activities, to understand different types of restrictive after and before. What is the difference between obstructive disease and restrictive? Obstructive disease and restrictive disease. Yes, inspiration, explicit outcome. Right? So, put it out. That is explicit. So both are basically tidal value. This is not tidal value. When we able to put the already on fixed value, tidal value is gone. Only the that definitely because the word chip. Very well. My also in the tidal value. Not like that. Simple. Even the T. V. I will be stronger. Our A and the normal price is right? And this is not down. Right? The A position of I am V. Incidentally, reason for you. Variable for you. And then this is here. Asking us to the volume, that is not. Right? Okay. Most of the after এটা কি নাম হলো সাইরন কি হলো সাইরন হলো সিস্টেম হলো সিস্টেম হলো it is called spiral clamp not clamp it is called spiral clamp so in exam theory it is written that just study the spiral clamp with all the problems and capacities then this is the right answer and then these are the volumes right now what are the capacities yes instrument right okay आगे जी वो आगे टाइम में कोई नहीं ताकि हम क्या है बेटा है राइट ये और so this theorem is RC आगे प्लीज now so long volumes and long capacities may come to the exam. Keep it calm. You have to divide fast with the static and dynamic. Two things are there. There is a long volume and long capacities. I divided into static and dynamic. What does it mean? Static and dynamic. So there is the dynamic is time, and it is not time at all. When it is time, that means it is slow rate. Slow rate means ml are made from oxygen. That is a slow rate. So we will follow this experiment for our problem. This is the ideal problem. Total respiratory system rate, either to test the electrical diagnosis, two things. Number one is the diagnosis, of it. Treatment is considered from the going to facility comparison. Right? And then also some sorts of treatment is going on, and identification is the position of the PLCO is preferable for the parameter for the animal durance or subscribe causing the abdominal fibrosis. Before you detect in the spirometry, you can detect early in vital PLCO. Right? Normally PLCO is done in also case of pulmonary hospital problems cases. Embolism and condition problems, embolism. These are the detected but on the PLCO. That means what are the full form of PLCO? PLCO full form is what is PLCO? Full form of PLCO. Yes. What is PLCO? Full form of PLCO. DLCO. DLCO. Second note. What is DLCO? Diffusion capacity of lung carbon monoxide. This is something like DLCO is now is for diffusion limited. After situation of diffusion limited, other situation of transfusion limited. That's it, like that. DLCO is the drug. In these cases, it is important to understand how we should go through it. How we DLCO for the confirmation. The spiral non-active production and another one is So, volume U. We get 2 U's. At the bottom of the so these capacities and the volumes to be defined how we will value. They have the decimal value then I don't know so this is important provider and now ask that you know about some sorts of flow volume. The external importance in the spinal tree, non-capacities, non-volumes, DLCO, deep sea diving, deep sea physiology, hypoxia, activizations, because periodic breathing, as well as asphyxia, hypoxia. It will not go and respiratory system usually comes from the body. Actually, the mechanics, cerebral, neural control, chemoreceptors, peripheral, and central. For who are which is the main stimulus for the peripheral chemoreceptor as well as which is the main stimulus for the central nervous. I don't know. There is a center. Main center is the order indirectly, directly is the and in case of filter, heat. You know, CO2, Roman cell, also Roman cell, and it is sensitive channels, oxygen sensitive channels, it is sensitive channels. These are important. Carbon or some houses to come. Where these leaders. Question. Same problem. The one side is carbon. You have to do something. Okay, I you will do it. Then what is the importance of that? Again, whether it is obstructing, whether it is restrictive. In case of obstructing, it is a interpersonal or extrapersonal or intrinsic or extrinsic. Whether it is these components in the spirometry already the practical concept of is done in Isaac. That is 2 to the 4 things can be predicted. That is how force, expiratory volume, and heat are given. FEV1 are that. F and force, vital capacity. So vital capacity and force capacity. Is it safe? No, why? Force. Control time. Time dependent. Then here, the parameter plus species. All of them are A to B1. Also, which is A B C. Also, which is A C B1 Y A B C. Ratio if B1 percentage. There is percentage of is F E V when B5 75 is 25 to 75 and then move them down. A down and excluding party is the charted after. There is a bit of this 50%. If we be 1, this is 1.7. 25 to 75% in the second. Where is it? A means of this thing. I have taken a mean expected flow rate. Mean expected flow rate. This is also called mean 50%. Not the whole. It is not hello. 0. And diamond expected to cause after the flow balloon comes after which to balloon for time comes to blow water like the way you are into which environmental physics whatever so very other like or another the individual of if you money and the force expected balloon and army business in forcefully charging in first second charging that is our P first second of what if you want the unexpected power A expected force vital velocity respecting first second balloon expressing voltage partial frequency Spiral approach, whatever is in full motion, and the computer is giving it power. You have a doctor, the computer has a doctor that is supposed to flow volume power. Another part of the that is volume time power. And volume time power volume. A volume time. Because volume and time is what? Time is second. You have talked about unconscious level after that people put it away and then it's done. That was one. Keep flow, keep expecting flow rate. After that, keep expecting flow rate. It means area not out of power. This is called volume time power. Let us see if we want. Right second, our next second, 2 second, 3 second, 10 second, 5, 6 second, 7, 8, 4. Let us start. This one. And if we skip the date, we are then that will be the theta. angle theta. So it is peak level. Peak means what? Peak steep motion is what? Peak expiratory flow rate. Up to which you can't, whatever you do, you can't increase the flow. That is the peak expiratory flow rate, and that is based upon this angle theta. Now, in your exam, suppose a double angle is a double angle. It is A naam B naam C naam, which is the maximum peak expiratory flow. A is the peak expiratory flow rate by A, B or C or A, B or B, C. Absolutely. And A, B, C. Angle. These angles different. Most of these angles is A. So the peak expiratory rate for A is high, and C will away. Right? Now, what will happen? The maximum point. Maximum point is first second the first second will be at the first second A the volume সেটা হচ্ছে কি নাম হলো F E B 1 এই ফার্স্ট সেকেন্ড আরেকটা নাম কি হলো F B C সেটা কি A the maximum point suppose it is the maximum point A is the most these changes this is of volume this motion of volume is called FVC. So the FV1 is FV1 means force of the force volume capacity. Always selected on the that's why the ratio is important. Not the single value is important to get it obstructive and non-obstructive. Individual value of the FV1 is important only for the severity or bleeding of the disease. Suppose that the patient FV1 is a bronchitis problem, but first in the dental and emotional is a moderate degree of obstruction and air obstruction, severe degree of and mild degree of that is a possibility. Circulation about that. The concept is that whatever it is in the one second, volume is we are getting the FV1. Suppose all the sample are over percent. ठीक है? अगर इनके रेशियो का तो रेशियो का 4.5 100 मतलब 80% is normal. 80% is a normal. The given the developed ratio that you will use if you give 1%. এটা বহুত বড় করতে তাই না this is not the ratio not only that the percentage of 51 percentage and this percentage are important only for diagnosis of the obstructive and restrictive now if you give one obstruction zero obstructive zero ratio is if you want that if you think you have open order or respect কাম আসলে কি হবে এইটা কত বেশি কমবে আপনাকে এটা কম কমবে তাহলে কি হবে এই রেশিওটা কমবে না বাড়বে ভালো কমবে এগুলো তো কিছু না কমবে is less than 70% mostly theoretical is 80% normal if it is less than 70% that is the standard case of obstruction standard case of obstructive disease now last day well this example of obstructive disease কি ভাবছি you know ঠিক আছে well give 2-3 examples of obstructive disease They will have to টাইমস করতে পারো কে বলুন এক দুই চার অনেক আছে সবাই করতে পারবে ঠিক আছে এটি বলবো as one ঠিক আছে and the restaurant that নাম বলছিলাম কিনা দেখো reality এভাবে disease মানে অন কনসিস্ট হবে আপনার কোন সিঙ্গার করতে হবে reality then and was only legal problem then one of the examples that provide one of the common issues then those problems because one thing is those are 65 also okay please for 5 important examples of the abstract disease. Respiratory disease is not so all these unbalanced are then disease cirrhosis okay what you will do Yes, all the words on that. You know what is that? Also, you know, attachment. You will do your harmony, diffusion. Students who are right, there is structural right experiences, lot of then you know that already also mass is number these are this is for the muscular action problems I want to ask you guys the number syndrome nothing is so what is the basic the basic problem as soon as that is the number now number is antibody against the voltage receptor I have to post synaptic it is acid against it that is the one you want to then otherwise restrictive and obstructive mind করতে একদম ওটা সিম্পল হ্যাঁ একটা সিম্পল কি আমাদের কোনো মডেল ফর্ম করতে দ্যাট ইজ কল্ড obstructive এন্ড হ্যাঁ আটা সিম্পল কি এই যে লক্ষণ দিয়েছি সিঙ্গেল করে ঘুরবে না কিন্তু এই দুই বলছি ঘুরবে না কিন্তু কি হবে রিকভার করবে কিন্তু এই কি বলবো দ্যাট ইজ প্রবলেম অফ inter-organ or extra-organ problem of obstruction. That is called obstruction. So this is not the volume kind of, and here it is depicted as ABB1 and ABC. So this is obstructing problem. A B common concept B obstructing we will want to do next one. Especially for our bigger angle is this, so we will do this. So in this way, we have to see what is FB1 and what is FBC. And FB1 is done in respect of FBC. Over respected with the 40%. That is 40% of FB1. And FB1 percentage, if it is less than 70%, is obstructing problem. But in this restricting process, here, restricting process কি হবে F51 2 আর ABC ABC AC বলতে AC বলতে তাহলে কি হবে এগুলো আগে so in your spirometer you see the normal level of F51 and FBC ratio then you have to think restrictive pronoun don't do approximative pronoun always if you are the master things you have to less than 70%. That's a very different. Less than 70%. Number two, if the spiral tree, F51 by FBC is increased, that is 100% is the uniform recipe. But if F51 and FBC is not, that the possibility of the recipe is not the possibility. Let's say, spirometry for the bioactive not something. Fine. These are the obstructive PSP. What do they do? They will be the exam. They will be like what do they watching fast? What do you see? He action and only he exam. After that, watching fast. Did you know? So, this is for the volume time fast. Also we flow volume power. That means the spirometer was equal. Flow volume power. Is flow volume power spirometry other criteria. যখন কোন পার্ট আমার উপর দিকে যাবে উপর দিকে যত পাওয়া আছে এক্সক্লুসিভ নিচের দিকে যত আছে এক্সক্লুসিভ এরকম রামপুরা This is a now computer so nucleology and those were not two for the mind of those who are converted. He however access to this is not the negative or positive relation. Another relation. This is the equivalent diagram that we decrease to Akula here. Total number. Total number. Very shallow. Very shallow. Hard one the technique is really for a program. Target to the bottom. Then you will flow it decrease, and like that, now you have to residual level. You already know that in case of spirometry, residual level cannot be detected by the spirometer. But theoretically, if you understand this is the inspiratory phase, and this is the expiratory phase, and these are the flow rates, and this is the point, this is the peak expiratory flow rate. Peak expiratory flow rate, and then down, and after this is the residual levels. There are two levels of problem. Now, one important questions I like to mention when I go ahead what is the clinical or forensic importance of the residual levels? Forensic importance of this is argued. Any idea? This is the that's why I was very much strong at that point of the course. After presenting very possible. And the exit to come. And then I was senior secretary of the graduates of the exit to come. And after that, and then so many of you that is What do you mean Typically, is not. You should stop. Associate. We always do the in case of any type of life science. In case of steel law, you should not jump. I got attending a level and that is the steel law. I simply rejected for the simply rejected. That is the main point. Simply rejections. So doctors also asking that that's why this subject is there as a great source of legal problems, something there, something modern and but still, as a mediation, I have to look upon my quotations. If I know which one it is, you can do that. But that is the problem for the forensic. And coming at that is the idea of the residual problem. So I rejected it. I am pretty statement of my staff that was just to work to do legal resolution. And I'm reading this. Right? Then you want me, but the important part of how you do this because the patient claims that he killed my child after the injury. So he killed my child anyhow after delivery. So his baby was a dead child. This is very unfortunate. The dead child was after 9 months of their marriage. But still, I have not myself. That's why you can't answer. So, I simply say, for the forensic and take the lungs of their child and once you can tell whether the residual problem is present or not. If the baby come out and break, that must be some problem is present. So, if the baby is kicked with lung issue, with the trauma of water, if it is here, present inside the lung, then it floats. It will float, and when it floats, that means our existing level, and I can be arrested. But that was undone. So there was no residual problem at all because it's too far. If it come out on the womb, then the baby was dead. Simple reason, within 3 to 5 days, the both came finished. And then they realized that I appreciated what I have done. Because still what I do. Always from the danger, we have to inform that the baby is that's the legal one. As a patient, it is not you are a that's not my issue. Our hearts are every life is that something I will listen to this from my hand and I can to save the child. So, in our view, the immunization program is very important and good one in hospital also. And because of this, is very well known by senior. So, he is doing a very great job. So, we are therapies or therapies, not necessarily. But here is that we can feel this like that. So, always every knowledge that we see. So, now on the original level, the outside of the suddenly, we can do forensic expert to get I will say by super just for the forensic department and postmortem is ready. Conduct one piece of time and then if it is routine, I will decide whatever they will file and continue materially and do that. But if it is not, there is a real self. So that I don't know. You can know your see. So that is what the importance of the respiratory in army physical body in consequences. Anyway, so this is up to this physical body and up to this PLC. First, this is a first paragraph. And a quick explanation for it is a quick. Now the question is that why this is quick? I mean, but I cannot hold the connection after this before. That is called dynamic fluid relation. That is called dynamic So, limitations. P is one line. It is simple. Dynamic for resistance means very simple. Suppose this is your branching and bicycle going on, branching and yeah. So whatever you are explaining, that means here is go have to move from active to this one. Suppose this is your A one, this is your B one. So A to B to be your flow. If you say expression of the expression is what? That means pressure is and 60%. At the end of the day, I can ask for the 761. I go, I am a person, 60 years. So, you do not only the reaction in this here is pressure is drop by drop. And again 61, another 7, 60, another 50, 99, something 1. And you will drop on the should drop. Pressure drop on the three sides. Number 1. Number 2. Pressure drop on the resistance. What kind of resistance? Frictional resistance. That is called air frictional resistance. That means frictional resistance to air. That is limited at R AW. Air resistance. That is also important. This is happening in here. Now, it's also depending on the velocity. Depends on the velocity. What do you mean by velocity? Velocity is basically flow and area. And area means cross-sectional area. If cross-sectional area is more, then velocity will be less or more? Yes. If it is less, it is more. More is less. The area, cross-sectional area is area should be against the cross-sectional area is center. And more area the cross-sectional. The cross-sectional area will be area which you are. The velocity is here. Right? There will be velocity to receiver, not pressure will come. That is called trans-level pressure. It is going to be original. Air pressure minus flow pressure. And actually, air pressure minus flow pressure. This trans air pressure. It will keep on landscape. Expand body of clouds. This pressure. Let's say, expression after the peak, the reach peak volume. That means pressure ultimately is flow rate. Flow. Flow rate flow rate velocity. Pressure dropping is more and this pressure inside the air will be less. So if it is less, dropping is much more rate. Pressure will be causing the narrowing of this one. If this narrowing happening as well as the R is the same, ultimately flow rate will be less. Whatever will be the volume of this. Pushing that. Cycle. Flow rate will decrease. Ultimately, it will come on the area of the physical volume, and then this will be again the expressions. Area after they have the during period this will the expression of power. Another idea is the positive and negative amount. Here says area equal to higher confidence. Let's check. Now this abstractive cause. Abstractive cause is obstructing causes of artery. Here, obstructing মানে কি? বের করতে পারছে না। আপনি ভাবে বুঝলেন? হ্যাঁ? বেড়ে গেল। তাহলে আপনি বেড়ে দেখেন পারেন। আর কি হবে? আর কি হবে? এফআরসি। এফআরসি মানে কি? পারেন না? Incident of corruption, experience of corruption, and the legacy of right? Total number of I don't know. Let's take it short form. Let's take it short form. Now, whenever it is dealing with the flow molecule, if the move is transported in the left, then it is not obstructing. Restrictive is transferred in the mind. R for R. Right side means what? Easy. The arm will be passed in this way. This is for the right second of this soul now. Mostly deep. Restrictive arm. Restrictive arm for right. Now it is going like that way. Air way. Here, that's it. Here, air way. Air. What is this term is called? Moving. Very good. This is called moving also. So moving. And also it is situated to the left of the restrictive right. Is a restrictive right. So these terms we have to again and again to do the correct and also if you deal with restrictive cases for your exam paper, you have to shift this curve to the right side. And all the bubbles and capacitors almost will be decreased so that if you give one and increase the ratio, either increase or not. But in case of obstructive, that means flow will come, it is shifted to the left, and if you want and if you see to be less than 70%, that is fixed. If you want to get the percentage individually of each stage if you want, then you have to carry forward the percentage of if you want to each ratio to respective degree. Suppose whenever I am going to obstruction, how can we use zero? That is the obstruction between 0 or obstruction between 1 and you started to say obstruction. How can you detect that or one can have obstruction. How can you detect that? In that case, one of the important things is that the component is it will increase, it's definitely 100%. Therefore, gives you acceleration. So, first of all, which one you want to first see? Issue. If it is less, then we have to see the heat, efficiency. If it is efficiency, we have to think about what kind of construction and so do the PLCO, that is diffusion limited heat, diffusion limited carbon dioxide capacity. These things are happening, and so this group is very important to understand and get it the restrictive restrictive. So restrictive inside obstructive. Every temporarily used to differentiate between these and these. Obstructive with the suitability and obstructive with the non-cancer, is for the disease. And this big restrictive for the air is for already a quantitative তাহলে একটা পেশেন্টের নম্বর তুই বিক্রি করতে পারবো একটা পেশেন্টের ডাক্তার আয়াতে বলে নিউমো হয়ে গেছে তাহলে এর এই কম্পিটিশন হচ্ছে তাহলে আপনি কি তাহলে আমরা টাকা কম হবে তাহলে বলবো তাহলে টাকা কি রকম হয় কথা আমার সব দিকেই নষ্ট হচ্ছে একদম চলে গেছে তাহলে আমার টাকা হবে আবার সাক্ষী তখন হচ্ছে বিক্রি করে in case of obstructive disease, please extremely slow, little bit down, more down than the pain. এখান থেকে যদি আর অপশন থাকে যে আমার অবস্ট্রাকশনের জন্য obstruction and these are big flow. Disease will be down of normal. Normal level flow, but the feet also it also normal. It also normal. So everything is low. Restrictive on but not much than the obstructive flow. That is your extremely flow will be less in obstructive and restrictive flow. In case of obstructive, extremely flow will be much more or less lower than the restrictive. Number one, if it is in the influences is obstruction is there, so there is no such thing. There are flat variables. So like how you can diagnose this. Whereas I will not only take the obstructive and restrictive, it takes the any disease along with the obstructive in the lung. Whereas so fibrosis, tumor, cancer, everything these things happens, it will be transferred by this flow. Any questions of this? I will so this is absolutely science and physics mostly is there. These are important for the exam, some exam also. And so if you are to know in this exam, this is also important for the professional education also. So be very careful. I have already finished my power chapter. Now they will be and the juniors will pass in. Then if you have any interest in any special topics of anything, say you can say ask, then we take the success. Even now, specifically, because they are going to ready to the area. And series is going on, there is a series chapter is very young. So if any subject that is important for the exam, you are not study. So please, you can really get introduce to make a fixed routine. I can do it in our sessions. Okay? Thank you very much.
কিরকম থাকে অবলিকটা তো কিভাবে থাকে এইভাবে থাকে তো অবলিকটা কিভাবে থাকে how does it will form it will take origin from the sternum and the clavicle and where it is going mastoid process আমরা অবলিকটা কিরকম করে থাকে so অবলিকটা থাকবে suppose this is the mastoid process this is the clavicle so one end would be like this okay so this is which border this is posterior border of sternocleidomastoid okay and this side you are having the anterior border of trapezius okay so which thing will form the base for the key medial two-third of clavicle right this one is the by the medial tooth so this one is the sternocleidomastoid which border again it is the posterior border okay again it is the posterior border and trapezius which border the anterior border of trapezius could you tell trapezius original insertion and what is this? Clavicle. Clavicle which thing? Medial two-third. Trapezius এর অরিজিনাল ইনসারশন বল কোথায় হতো? Trapezius এর অরিজিনাল ইনসারশন কোথায় হতো? So if you see the nuclear line মনে তো superior nuclear line কি কি তিনটে মাসেলে অরিজিন হয় কি কি? একটা হচ্ছে তারপরটা হচ্ছে sternocleidomastoid, তারপরটা হচ্ছে splenius capitis. The trapezius এর অরিজিন কোথায় হলো? Medial part of the superior nuclear line. ঠিক আছে, এবার ইনসারশনটা কোথায় হবে বল? Very good. So it is on the scapula. It is on the scapula, both sides, and it is forming one rhomboid shape on the posterior surface of neck. বুঝলো, superior nuclear line থেকে এইভাবে একটা rhomboid form হচ্ছে. Okay, so this is the boundaries of the posterior triangle. Okay, so just write it down now. Which structure is making the roof? Okay, so roof for anterior triangle and posterior triangle are different. Okay, anterior triangle এর রূপটা বল কি কি বলেছিলাম আমি? Skin, then superficial fossa. What are the content? Superficial fossa কি কি content পেয়েছিলি? Platysma or there is one jugular vein, which jugular vein? Anterior jugular vein, and both side right and left দুটো আছে দুদিকে. Okay, আর there is lymph nodes, submental lymph nodes, and the submental branches of facial artery. Okay, this is the superficial fossa content on the anterior triangle. What about the posterior triangle? Again, write it down. Posterior triangle. Posterior triangle. The roof is formed by. So, if you are talking about the roof, so how does the roof will form? So, number one is skin. Okay. Then comes superficial fossa. Now the question is, what are the content of superficial fossa? Superficial fossa কি কি content হবে বল? সুপারফিশিয়াল ফাসা এখানে যদি থাকে তো জুগুলার ভেন, অ্যান্টেরিয়র জুগুলার ভেন হলো ওখানে কি থাকবে? পোস্টেরিয়র জুগুলার ভেন. Okay, and it is also a content of both are coming from where? Anterior and posterior. Both are coming from external jugular vein. So external jugular vein itself is a content of posterior triangle. Total. Okay, the first content, write it down. First content পাবি. Again platysma will come. Okay, platysma will come. Then second one is external jugular vein, and posterior jugular vein. Okay, and additionally there are four nerves. Okay, additionally there are four nerves. Which are they? Write it down. First one is অনেকগুলো content আছে. Okay, posterior triangle having lots of content. So if you talk about superficial fossa, first thing you will get the platysma. Okay. Second one you will get the external jugular vein. Okay. So one thing about the external jugular vein, write it down. Two clinical anatomy associated with it. With the external jugular vein. Number one is where to locate. Do you know where to locate? Surface anatomy of external jugular vein কোথায় হতে পারে? So you will get the structure over here. Okay, at the corner. Okay, at the side of the clavicle and where the sternocleidomastoid start. Okay, there you will get the external jugular vein. So write it down. External jugular vein is piercing the deep cervical fossa. It is piercing the deep cervical fossa. Okay. So if it is piercing the deep cervical fossa, so suppose the cut has been made. Okay, by anyhow the injury has been made to this area. What will happen? Injury or the cut to this section of the neck. What will happen? So as because, write it down, as because external jugular vein or AJD is the content of the deep cervical fossa itself. sudden cut or injury to this surface will also leads part of the external jugular vein, isn't it? So what will happen? Suppose other vein is there is any cut, what will happen? Cut hole ki hobe? Vein e cut hole ki hobe? প্রথমে kind of bleeding হবে, right? Passive bleeding হবে, afterwards কি হবে? Vein collapse করে যাবে, but it is not occurring in case of external jugular vein. Okay, why? Two reasons. One is it is the content of this deep cervical fossa. Okay, ওই ফাসারি content, সুতরাং ফাসাটা ডাইরেক্ট থাকবে, ভেনটাও ডাইরেক্ট থাকবে. This is one reason, and it does not got any pulse. Okay, so write it down. So if any cut injury to the deep cervical fossa, it will also cause part of the external jugular vein, but it does not collapse. Okay, as it relaxes during relaxation of the deep cervical fossa, due to relaxation of the deep cervical fossa, and another one, it does not contain any valves. তো এবার ধর যদি কোনো ভাবে কাটটা থেকে গেল vein and vein surface is open, what will happen? The air will go to that area. যদি air ঢোকে কি হবে? There will be air embolism, pulmonary embolism, and it will cause sudden death. So that's why it is very much clinically important. So এটা number 1 point of the external jugular vein. আরেকটা কি important point? Second one, from here we used to measure the venous pressure, central venous pressure, যেটা আমরা CVP লাইন করি না, সেটা কোথায় করি? এই external jugular vein করা. So write it down, to measure the ICCU তে যদি গিয়ে থাকি স্যার দেখতে পাবি. ওকে, jugular venous line কি করে পড়ে, external jugular vein. ওকে, so why we are taking the pressure? কেন এখানে central venous line করা হয়? Because it will give you the accurate reading. হার্টে কি চলছে সেটা কিন্তু external jugular vein বলে দেবে. How? Because it is having same pressure as the right atrium. Okay, so write it down. Second one, the external jugular vein is used to measure the central venous pressure, during ICCU and emergency procedure. Because it coincides with the pressure of the right atrium of heart. It coincides with the pressure of the right atrium of heart. So these are the two clinical anatomy related to the external jugular vein. And how does it will form? External jugular vein কি করে তৈরি হয়? Do you know? It will form on W. I said how? Write it down. External jugular, এটা কিন্তু MCQ আছে. External jugular vein is formed by posterior auricular vein. Posterior auricular vein you are aware of, কোথায় থাকে? Just behind the ear. So first one is the posterior auricular vein. আরেকটা কোন vein? Posterior division of retromandibular vein. Okay, posterior division of retromandibular vein. So these two will form the external jugular vein. Okay, but external jugular vein এর কি কি tributary পেরি? একটা পেরি anterior jugular vein in the anterior triangle, another one is the posterior jugular vein. আর anterior jugular vein কটা আছে? Both side two. Okay, which will again join with, কার সাথে জয়েন করে? এর আগের দিন বলেছিলাম, it will form one arch. Okay, left and right, this anterior jugular vein, it will join the external jugular vein. তাই না? venous drainage টা এখান থেকে নিয়ে গিয়ে external jugular vein এ বের হবে. Okay, now next one is the nerve. Write it down, which are the nerve. So first one you got the vein, external jugular vein and posterior jugular vein. Now coming to the nerve. How many nerve are there? As many as 4 nerve. Which are they? কি কি নাম বল? Do you know which are the superficial nerve? Superficial nerve. এটা ডিপ সার্ভাইকাল ফাসাতে পড়েছে। ওকে, ডিপ সার্ভাইকাল ফাসায় অনেকগুলো কি করে প্রিভার্টিব্রাল ফাসা থেকে ইনভেস্টিং লেয়ার অফ ডিপ ফাসাটাকে ক্রস করে সামনে আসে। ওকে, so write it down. First one is the lesser occipital nerve. First one is the lesser occipital nerve. কোথায় পেয়েছিস এর আগে? Lesser occipital nerve. Where you got? Lesser occipital nerve you got on the scalp. Scalp पे पेয়েছিলি না lesser occipital, greater occipital, third occipital, है ना? So first one is the lesser occipital nerve. Root value কত হবে? C2. Root value হবে C2. First one is the lesser occipital nerve. Okay, root value কত? C2. Then second one is the great auricular. Great auricular কোন এরিয়াতে সেন্সরি সাপ্লাই দেয়? जैसे throughout face sensory supply কি বলেছি? From the trigeminal nerve, তাই তো ophthalmic division, maxillary division, mandibular division. তাহলে কোন এরিয়াটাকে দেবে না সেটা দেবে, that will be provided by this great auricular nerve, that is nothing but the angle of mandible. Write it down. Angle of mandible of the face, sensory supply of angle of mandible is supplied by great auricular nerve. Root value কত? C2, C3. Okay, then the third one is transverse cervical nerve. Transverse cervical again is C2, C3. বুঝা গেল? Transverse cervical nerve. Last এটার কি নাম বল? Last এটার নাম হচ্ছে supraclavicular nerve. Okay, supraclavicular nerve. এর ভ্যালু কত? C2, C3, C4. ঠিক আছে? So these are the four nerves you will get on the posterior triangle. So this is only I am talking about the superficial fossa. Okay. So next which thing will get? Once you take out the superficial fossa, you will get the deep fossa. Okay. So deep fossa কোন layer গুলো পাবি? Write it down. Deep fossa are investing layer of deep cervical fossa. এই চারটি না ভীষণ ইম্পর্টেন্ট। Okay, so deep cervical fossa হচ্ছে investing layer of the deep cervical fossa. Okay, then coming to the floor, very much important. Floor টাকে তৈরি করছে। So see, if you see the floor of the posterior triangle, you will get all the muscle, layer of muscle is covered by a very thin layer of fossa. Okay, that is nothing but prevertebral layer of deep fossa. Okay, so write it down. All the muscle which are present on the floor of the posterior triangle, the floor of the posterior triangle are covered by কোন লেয়ারের সাথে কভার থাকে? ভীষণ ইম্পর্টেন্ট, prevertebral layer of deep cervical fossa. Okay, so suppose how you will take the dissection line for this posterior triangle. Posterior triangle টা কি করে লাইনটাকে dissect করবি? First thing you have to say, we are talking about the posterior border of sternocleidomastoid, right? But we won't cut on the posterior border. ঠিক আছে, কোন বর্ডারে কাটবো? anterior border. কেন posterior border কাটবো না? So এটা explain by আসতে পারি, write it down. The dissection line for posterior triangle is always made on made on anterior border of sternocleidomastoid. Anterior border of sternocleidomastoid instead of posterior border. So কি আমাকে রিজনটা বলবে, রিজন কি? Explain me this why. যদি ধর posterior border থেকে কাট করি কি সমস্যা হবে? Because you are seeing all the superficial nerve, it will get cut. Okay, so write it down. All the superficial nerve which is originating from the posterior border of sternocleidomastoid. You have to name this four nerve. Okay, originating from the posterior border of sternocleidomastoid get damaged. Used to get damaged. Okay, so that's why we are giving the anterior line. তাহলে প্রথমে ইনসিশনটা কোথায় দিবি? On the anterior line. Okay, so we will give one incision to the anterior line. Okay, এখানে একটা ইনসিশন হয়ে গেল। আরেকটা ইনসিশন কোথায় দিবি? From the sternocleidomastoid to the এটা ক্ল্যাভিকলের কোণে lateral in clavicle তাহলে এখানে একটা আরেকটা ইনসিশন দিবি। ওকে, আরেকটা ইনসিশন কিন্তু যেটা দেয়া হয় সেটা হচ্ছে you should not cut this area. ঠিক আছে, নেকের সাইডটা কাটা যাবে না, ট্রাপিজিয়াম সাইডটা কাটা যাবে না, কোনখানটায় কাটবি? বুঝা গেল? Just to reflect the skin away. Okay, so these are the three incisions. Okay, so now we are talking about the flow. So once you have taken the skin, once you have taken the platysma, you will come across the superficial nerve, then coming to the prevertebral layer of the left cervical fossa. So you have to just take it out. It is a very thin layer. Once you cut, there are as many as 4 muscles. Okay, one by one. So first one is, write it down. প্রথমে কাকে পাবি? এই এরিয়াটাতে কাকে পাবি? First এরিয়াটাতে পাবি splenius capitis. Okay, this one is for the splenius capitis. Next one is for levator scapulae. Okay, and then next one you will get purotype পাবি the scalenus medius. বুঝা গেছে? And additionally you will get over here আরেকটা মাসল পাবি যেটাকে বলছে supraspinous capitis. Okay, so this is another one, semispinalis capitis. Last one is the semispinalis capitis. Okay, so write it down. Floor is occupied by splenius capitis কোথায় পেয়েছি সেটা আগে? splenius capitis কোথায় পেলাম আমরা? superior nuclear line. superior nuclear line এর সবথেকে lateral line, মানে ফার্স্ট কন্টেন্ট কি? splenius capitis. Second one is levator scapulae. levator scapulae কিসের মাসল? হ্যাঁ, so where is the origin? levator scapulae মনে আছে origin কোথায় হবে? যেদিকে তো glenoid cavity আছে সেদিকে না, উল্টো দিকে, যেখানে স্পাইনটা শুরু হচ্ছে কর্নার, সেখানে হচ্ছে levator scapulae। কি মেইন ফাংশন? To elevate the scapula. So you will get the levator scapulae. Third one is, 3 number কাকে পাবি? scalenus medius. scalenus medius is a muscle of কোথায় পেয়েছিস বল? scalenus medius তিনটে পাওয়া গেছে। So that is nothing but content of the rib, তাই না? ফার্স্ট রিবে পেয়েছিস scalenus medius, scalenus anterior, scalenus posterior। ঠিক আছে, scalenus medius তাহলে পাবি, আর এটা হচ্ছে semispinalis capitis। এটাকে কেন মেজর কন্টেন্ট বলছি না? because each and every individual has got different structure of the posterior triangle. Okay, but you will definitely get these three muscles. এই তিনটে মাসল পাবি। additionally superiorly কাকে পাবি? semispinalis capitis। ঠিক আছে, inferiorly সেইভাবে আরো তিনটে মাসল পাওয়া যায়, which are they? কি কি পাবি? scalenus medius along with scalenus posterior of serratus anterior. Okay, এদিকে একটু লিখে নে। Additionally, post এই এরিয়াতে দেখ এই এরিয়াটা যেখানে শেষ হয়ে গেল, so that is the scalenus medius. So you will also get the scalenus posterior. Scalenus posterior. Then next one is scalenus anterior. আর serratus anterior কতগুলো ডিজিট আছে? How many digit? Serratus anterior and supplied by which nerve? Serratus anterior কটা ডিজিটেশন আছে? ডিজিটেশন না, it will take so many digital origin. তাই তো? 8 digitation. ঠিক আছে, as many as 8 digitation. So among them, huh? 8 digitation. Okay. So we are having only first digitation of serratus anterior কোথাকার muscle? It is also known as কি muscle বলা হয় এটাকে? boxer muscle. And it is supplied by which nerve? So that is also known as nerve of Bell. It is also long thoracic. ঠিক আছে, এতগুলো ডিজিট কে সাপ্লাই করতে হবে, এটা লং thoracic nerve of Bell. Okay, so this is about the nerve, the floor of the posterior triangle. Okay, now we are coming the subdivision. Anterior triangle subdivision কোন মাসল করেছিল? কটা সাবডিভিশন আছে? চারটে সাবডিভিশন আছে, 3 and half. Half is the submental triangle. আর তিনটে সাবডিভিশন কি কি হলো? একটা হলো তো digastric or submandibular triangle, আরেকটা হচ্ছে carotid triangle, আরেকটা হচ্ছে muscular triangle. So that have been done by which muscle? Superior belly of omohyoid. এখানে কি সেপারেট করবে? Inferior belly of omohyoid. Inferior belly of omohyoid is inserted where? কোন বোন থেকে নিচে অরিজিন? তো সুপিরিয়র বেলি, ইনফিরিয়র বেলিটা কোথায় যাচ্ছে? Again it is scapula. Okay, again it is scapula. ঠিক আছে, so inferior belly of omohyoid. So how the subdivision has been made? So write it down. Posterior triangle is divided into two subdivision. Okay, so this is suppose the posterior triangle. Okay, so where the inferior belly of omohyoid কোন জায়গায় থাকবে? So এখানে থেকে লিমিটার স্ক্যাপুলি আছে, এর থেকে একটু নিচে। ওকে, এই রকম একটা জায়গা করে ক্রস করবে। ওকে, so that the whole posterior triangle is divided into larger, এটাকে কি বলছে? occipital triangle, and smaller supraclavicular. It is also known as আরেকটা এটা কি না? omoclavicular. ঠিক আছে, নিচের পার্টটাকে বলছে omoclavicular triangle. So subdivision has been done by inferior belly of omohyoid. কি কি ডিভিশন দিল? একটা হচ্ছে larger occipital triangle, okay, and another one is smaller supraclavicular, or also another name is omoclavicular. Okay, so it has been divided into two subdivisions. Okay, now one by one triangle we will discuss. So there is one difference you will get in your textbook. Okay, between the difference between the occipital triangle and the supraclavicular triangle. Which thing you have to know? What are the content? Okay, difference between the content. Okay, so write it down. First one is for the occipital triangle. সো এবার বল অক্সিপিটাল ট্রায়াঙ্গেলে কি কি কন্টেন্ট হতে পারে? অক্সিপিটাল ট্রায়াঙ্গেলে কি কি কন্টেন্ট হতে পারে? এই সব কটা নার্ভ, যতগুলো নার্ভ পড়েছিস চারটে নার্ভ সব কটা কি কি বললাম? একটা হচ্ছে লেসার অক্সিপিটাল, গ্রেট অরিকুলার, দেন ট্রান্সভার্স সার্ভাইকাল, then last one is the last nerve will come? No, only 3 nerve. Okay, write it down. 3 nerve, lesser occipital, great auricular, and also the transverse cervical nerve. Okay, additionally you will get additionally you will get the occipital lymph nodes. Additionally, you will get the occipital lymph nodes. Okay. Now coming to the supraclavicular triangle. So what will be the content? So you know the supraclavicular nerve has got 3 divisions. Okay. So they are C2, C3, C4. বুঝতে পারলি supraclavicular nerve এর কত ডিভিশন? 3টে. All are directed downwards. All are directed downwards to the supraclavicular triangle. Okay. So additionally article pabi visual important structure, that is root and trunk of brachial plexus. Okay, root and trunk of brachial plexus. Now tell me root mane ki kon nerve asbe? Root and trunk of brachial plexus. Kon nerve asbe? All will come, but you have to specify the name. Nerve to প্রথম নার্ভটা কি? Nerve to serratus anterior. Number 1 nerve to serratus anterior. Or it is also known as long thoracic nerve or the nerve of death. Okay. আচ্ছা ওখানে আর কি মাসল আছে? You are talking about just below the clavicle. So which muscle is there? Subclavius. Right? So subclavius. So nerve to subclavius. And another one is below the scapula, that is nerve to subscapularis. Nerve to subscapularis. Subscapularis muscle টা কোথায় থাকে? Nerve to sub. Subscapularis বলে কোনো মাসল আছে? Scapular medial. Okay. Then next one is the scapular দুটো বড় ইয়া সারফেস আছে না, একটা তো anterior surface, একটা posterior surface. Anterior surface কে নেবে? Subscapularis. So that is nerve to subscapularis. Now coming to the posterior side of scapula. Which are the muscle you get? Main muscle. So there is a spinous process running. Has got 2 muscles, supraspinatus, infraspinatus. So next one is suprascapular nerve. দুটোকেই কিন্তু সাপ্লাই করবে কি? Suprascapular nerve. Okay, দুটোকেই সাপ্লাই করবে suprascapular nerve. So root and trunk of brachial plexus. These 4 nerve you will get. Okay. And additionally, which lymph nodes? Supraclavicular group of lymph nodes. And why the clinical anatomy of supraclavicular lymph nodes are important? When does it get swelled? Supraclavicular lymph nodes. বার করেছিস। The varicose lymph nodes. Gastric carcinoma. Okay, gastric carcinoma, you will have elevated supraclavicular lymph nodes. This is also known as varicose lymph. Okay. VIRCH varicose lymph. Okay, so these are the 2 clinical anatomy related to this 2 triangle. Okay. And additionally, what are the things you have to study in the posterior triangle? that the lymph nodes. Okay, একটা হচ্ছে তোর ওখানে occipital lymph nodes পাবি, এখানে পাবি তুই supraclavicular lymph nodes. আচ্ছা, omohyoid chiefly you will get on the supraclavicular triangle. Okay, so that's why you are saying omoclavicular triangle. Okay, so now we will go and see in the dissection. Okay, dissection of posterior